Welcome, everyone, to another edition of Three Plastic Surgeons and a Fourth. Today, we are poorly named as we are actually missing one of our plastic surgeons, but I am joined today by Dr. Lawrence Tong from Toronto, Canada, who is at Yorkville Plastic Surgeon, and of course, by our fearless leader,
Surgery.
Sam Rhee. Isn't it Yorkville Plastic Surgery?
Yes, but you said surgeon. It's fine. No worries.
Oh, I'm the worst. Sam Rhee at Bergen Cosmetic. That I do have down pat. And I'm Sam Jejurikar. I'm at Sam Jejurikar. Pretty easy. The two go together. So, and we're missing Dr. Pacella, who will join us, I'm sure, in the relatively near future. And today we're going to talk about an interesting topic that's definitely peripherally related to plastic surgery. It's about the obesity epidemic in the U.S. Before we get into the meat of it, Dr. Tong is going to read a disclaimer.
All right. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something on this show.
Okay, so what's prompting us to talk about the obesity epidemic today is a new study that was just published in the medical journal, The Lancet, which has gotten a lot of press over the last few days. And it showed that nearly 3/4 of US adults are now overweight or obese, which is up from just over half in 1990, which means our population is actually getting fatter. This is obviously an alarming trend that has wide-reaching implications for healthcare costs, for health in general, as obesity is linked to conditions like diabetes, heart disease, and shorter life expectancy. And the study highlights a troubling rise in obesity rates among children, with more than a third now overweight or obese, and warns that without intervention, the number of affected individuals could reach 260 million in the US by the year 2050. The experts are basically saying that the issue is an epidemic driven by genetic, physiologic, and environmental factors, including the prevalence of ultra-processed foods and sedentary lifestyles. They say that social aspects like food insecurity and income disparity exacerbates this problem, particularly in poor and marginalized communities. And while we have promising new treatments, specifically GLP-1 agonists that we have talked a lot about previously on this podcast, and I know they can offer a lot of hope, they're really expensive and right now inaccessible to the masses. So kind of opening up this conversation to a broader discussion and to this podcast, more specifically about plastic surgery. Have you guys seen this? Like, do you guys feel like in your patient populations that you're seeing that that more patients than not are overweight or obese that are coming to you for surgery?
I
My,
don't,
yeah, go ahead,
go
Sam.
ahead. I did for a while, and it is prevalent. There's no doubt that our society, especially in the United States, we as a population are getting heavier and more obese. I don't know what it's like in Canada, Larry, but for us, you can go to any large public setting and you can really see just how obese most people are at this point. For me as a physician, I mean, I have a couple thoughts. One is as a plastic surgeon that does primarily aesthetic surgery, I don't use aesthetic surgery as a means for weight management. And so I think most of my patients at this point know if they're coming in with a very high BMI, there's not a lot that I can offer from an aesthetic surgical standpoint that's going to address that. And I talk to them a lot about not using surgery first to address aesthetic issues related to weight or being overweight. And I'm pretty strict about that. I think I've gotten stricter as I've gotten farther along in my practice career. And also maybe because I don't know where Sal is because he needs to hear me talk about CrossFit because he always tells me what the first rule of CrossFit is. But I've gotten I'm now pretty heavy into CrossFit as a minority owner of a gym, and I also coach. I've attended the CrossFit Health Summit. I've learned a lot about what their ethos and philosophy is about fitness and nutrition. And a lot of what I think afflicts us as Americans today are things that are addressable not through surgery or maybe even medical principles, but other means that I think we haven't really focused on well as physicians in the United States. And I'm happy to talk about that a little bit. But I feel like we're putting the cart before the horse every time we talk about GLP drugs or surgery or other sort of more drastic, in my mind, measures to address patients who are suffering from chronic disease, such as chronic diseases related to being obese and overweight or being unesthetic because they're overweight.
So, when I moved from Michigan to Toronto, when I moved from uh, the United States to Canada, I actually did see a fairly marked difference in the number of patients that I saw that were overweight. That dropped fairly dramatically when I moved to Canada. That's not to say that everybody here is, BMI of 20, but I remember when I was practicing in the States, it was, you know, fairly common for me to operate on patients who were, 200 pounds. And that's something that's actually quite rare nowadays. And, um, I'd be curious to know if the epidemic in obesity is sort of special to the United States, or is it, uh, for Western developed countries as an issue? I think that what you said, Sam, is really correct. That there's a misconception sometimes that plastic surgery can fix obesity, but definitely that is not the case. There's no surgery in the plastic surgery realm that that can, you know, do enough to um, make an obese person non-obese, and I think that's important. Um, Something that I just want to touch on is um, our viewers and listeners might not know why it is that being overweight is a health concern, and so being overweight causes various medical conditions. One which is very important is type 2 diabetes. That is a metabolic condition where um, you can't regulate your sugars, and that's going to have cascading effects on your kidneys, on your vision, on your blood vessels. Another effect of being obese is it's a stress on your cardiovascular system. You'll get high blood pressure. It's bad for your heart. So all of these things basically can lead to more disease, shorter lifespan, poor quality of life. And as plastic surgeons, we have to look at these things because a lot of these things are risk factors for surgery as well. But I take Sam's point um, and agree with it that the obesity epidemic is not going to be solved by plastic surgeons. There are other things um, that are to be done way before it gets to us. And I don't know, Dr. Jejurikar, if you have any other thoughts.
Yeah, I mean, I think you guys have both said a lot. I will, the only thing I don't really have a opinion on is the relative healthiness of Canadians relative to Americans, just because I don't see them, but sounds like they're thinner than what you're seeing here. Sam said several things that I wanted to sort of expound on. The first thing that I noticed that you said is that you hadn't really noticed that your patients were necessarily getting fatter than they were a few years ago. And I would say I feel the same way. Like I mean, I definitely have different categories of patients that I see. Those that are, obese in the sense that they have excessive fat. They're not the majority of my patients. Definitely 3/4 of my patients do not fall into the category of being in such physical disarray that we're worried about their health. It's probably 25% or less. I agree with both of you. Plastic surgery is not a treatment for obesity. Um, Weight loss before plastic surgery is not only better for your health for all the reasons that Dr. Tong said, but it actually gets you better results with your plastic surgery as well. Pretty much any plastic surgery, whether it's facial plastic surgery, whether it's body contouring, breast surgery, getting to a weight that you're going to be comfortable living at is going to get better results. But then the final thing was some of the methodologic problems with this study. BMI is a really crude indicator for what our overall health is. And, Sam, you treat a lot of really muscular patients probably who come to you from the CrossFit world. I mean, your BMI would technically in this study, and you are one of the most fit human beings I've ever met with a large amount of muscle and very little fat would actually put you in the overweight or obese category because of the amount of muscle mass that you have. And I do think that there is a component of that with at least the population of patients that I'm seeing and that you're seeing, that many of my patients weight train or are engaged in, a lot of active muscle resistance exercises, take testosterone supplementation for building muscle mass. So I don't honestly believe, like when I look at my patients that I treat now relative to the ones that I did 10 or 15 years ago, I feel like my patients are in better shape. That's why I found this paper to be so interesting. It's something that I wanted to talk about because I just haven't seen a worsening obesity epidemic, at least in my population of patients.
I think part of that is because I think, especially when I first started my practice, I saw a fair number of obese patients who were looking for liposuction for weight reduction. But I feel like a lot of patients who are now obese and unhealthily obese realize liposuction is no longer been is no longer an option. I think most lay people are starting to realize plastic surgery is not the way to fix weight issues. For a while, I saw, and I think a lot of patients will generally realize I need to manage my weight first. And prior to GLP-1, I saw, obviously, and I'm sure you did too, a lot of patients who had gastric, bariatric surgery, some sort of gastric bypass procedure where they lost a lot of weight through surgical means. And I still see a lot of those patients too for body contouring, mostly because of the excess skin that they've developed after massive weight loss. So I think some of it is self-selection from our patient population. I think they do realize they're not supposed to come see us for weight management, or they don't feel like our techniques will help. The other thing is that we all work in fairly high income areas. Larry works in Toronto. You work in Dallas, and we have very affluent patients. So I think a lot of obesity and weight and problems with weight can be correlated to some degree, not always, but some degree, to income or demographics of some sort. And so the people who are probably suffering the most from weight issues are probably not the patients who are going to be able to afford or consider even aesthetic surgery or other types of expensive procedures to help themselves aesthetically. That's what I think.
I think that, when a patient does come who is likely, overweight to have, too overweight to have surgery, there are a number of things that we have to, explain to them. And so, what are some of the things that you guys would explain as to a patient, why they wouldn't be a good candidate for surgery?
I think let's imagine we're going to talk about body contouring surgery. That seems sort of like a logical extension based on the fact that we're talking about obesity. I think there's a few things. So one, if a patient is obese, and not because they're muscular, but obese because they genuinely have just too much fat within their body, the thicker the tissue plane is between their muscle and their skin. Number one, the harder it is to mobilize it and get it as tight. Number two, the greater the distance, these tiny little blood vessels and the microcirculation that they need to heal their tissue, the greater distance that it has to travel, and thus the greater likelihood they're going to have of wound healing complications. Number three, the more intra-abdominal deep fat or visceral fat they're going to have, and the worse the results will be. So I'll try to explain to patients, let's say I'm seeing a patient who is grossly overweight and their BMI is 35, which, I don't have an absolute cutoff for surgery at 35, but I don't think my results are as good as they are for someone who's going to be 30 or 25. And I'll explain to them, it would really behoove us to try to figure out ways for you to lose weight prior to surgery to get the desired results you're going to get. More often than not, people are motivated to do that. And between lifestyle modification and GLP-1s at this point, we can get some improvement. But every now and then, patients will say, I just can't. I've been on a GLP-1 or for whatever reason I can't. Is there anything you can do? And there are ways that we can modify the surgery to perform it more safely. The results, the before and after results, are still dramatically different. They're not as good as if they had lost weight ahead of time.
I mean, I think some of it is talking about lifestyle, as Sam said. All the things you said, Sam, about what makes surgery results not as good for obese patients holds true. Absolutely, they're all things that I say similarly. I was just thinking, do you guys still take call, like in the ER? Either of you? No.
No.
See, that's the thing. Neither do I. And I do know my colleagues that are seeing patients in the hospital are seeing a lot of patients who are extremely obese. I see a lot of case reports during M&M conferences at my hospitals, which I still attend. And they're doing lower extremity reconstructions. They're doing trauma. They're doing other fairly complicated surgeries on patients. And it's very routine for them to have very high BMI patients, which complicates the results of these fairly complex surgeries that they're often doing on patients with issues that are often related in great part to the chronic conditions they have due to obesity. I think we're operating in a very rarefied space where our patient population is not subject to many of these issues. But I feel like if we actually sort of opened up where, and we chose that. That's what we wanted. We didn't, that's what I chose, at least. I did not want to take call. I did not want to I wanted more control over my life. I wanted to do more of what I wanted to specialize in. And so I did not want to do venous stasis ulcers on a patient who smoked a pack a day and was over 250 pounds. Like that just wasn't, but there are a lot of plastic surgeons who do. And for those who do, I would say they're seeing a whole spectrum of issues based on, I think, results which I think are legit and valid from what the Lancet's saying, that we are an obese population and we're just getting more obese.
Yeah. So then let's make this topic then a little bit more specific to what this podcast is about: plastic surgery and aesthetic patients, and our listeners who are all going to sort of be in the same rarefied air as what you're sort of describing. So imagine we're talking to a patient who is struggling with weight loss, and they are in the overweight category, a BMI of 25 to 30. We'll talk about this patient first. And they're interested in a tummy tuck and liposuction, and they come into your guys' office and they'll say, Dr. Tong, Dr. Rhee, I'm struggling to lose more weight. What can you do for me? Will surgery be beneficial to me? How will you respond to this patient?
Well, for me, what I do is I will say, you're a great candidate for the procedure, but not exactly at this time, right this very second. I will say, like, I do see a fair number of patients exactly as you described, Sam. And I will say, let's work with you and give you some time to get you to the weight that you want to get to first. And I will ask them, are you happy at the weight that you're currently at? And I can say pretty much 99% of patients will say, no, I'm not happy at this weight that I'm at. And I would say, well, what is your livable, everyday, manageable weight? Not your weight that you were when you were 21, before you had 3 kids, but the weight that you think you could hold on to from this point forward. And most of them will name a weight somewhere between 10 and 15 pounds, maybe some aggressive patients, maybe 20. And I'll say, great. All right. A lot of what they need is to take a good look at themselves and their lifestyle and figure out what is it that's sort of holding them back from reaching that weight. And generally, there are 3 main issues that patients I see have that I talk to them about. What's your stress level like? What is your nutrition like? What is your lifestyle like in terms of exercise? And all of those things, they generally will take a hard look at themselves. And the ones that are motivated, who really want to achieve the best results in terms of their aesthetic surgery, will start to make some moves on it. I don't necessarily recommend one thing or another. I don't say CrossFit. I don't say keto. I don't say paleo. I don't say any of that stuff. I will basically tell them whatever means you feel like works for you, whether you start small or big, you need to start making some measurable improvements on. And most patients, it's not perfect. I know a lot of patients may find that too difficult, maybe at their stage in their lives, or maybe they just have certain issues in their lives that are holding them back. But a lot of them, surprisingly, I will keep in touch with for a month, 2 months, 3 months, and they will actually make big gains in terms of improving their life to the point where they can get to be ideal candidates for surgery. I will say the GLP agonists have helped for a lot of patients in conjunction with lifestyle changes, but it's not magic. And I know a lot of patients have had some side effects like intractable nausea and vomiting and other issues. But I feel like all of these things combined there are more options for patients who are considering aesthetic surgery who are in the obese or overweight category than there were previously available to them, say 10 years ago.
I think that when I talk to patients in this situation, I can usually categorize a patient as someone who's wants this surgery because they sort of want a shortcut to look better, and other patients who are truly motivated. And I think that if I go through that same sort of talk that Sam just went through, the patients who are motivated will actually, you know, take something from what I've said, lose weight, come back and actually have the surgery. And then, there's a certain number of them who will basically leave and hear what I've said, but not really do anything, and then they'll never end up having the surgery. And I think that those patients might not have had, if they did go through the surgery, long term probably would not have had a good result. Anyways, you've all had patients where they were a little bit overweight, they wanted to lose weight, did liposuction on them, and then 5 years later they came back and they gained everything back and more. So I think that sometimes you can't help everybody. You try your best, but sometimes you're not going to be able to, not everybody's going to be able to have cosmetic surgery and have a great result. It's hard job.
And just to be clear, we're still talking about patients whose BMI is 25 to 30, or are you thinking about a higher number when you're giving this response?
Yeah, I'm more thinking about a higher number. 25 to 30 is actually
fairly normal.
Yeah, exactly.
Many of the patients that I see.
That's not bad. So maybe I won't be having a talk for 25 to 30. Like 25 is very reasonable.
Exactly. I just wanted to make sure if we had changed a little bit in our focus. Yeah, I thought Sam's explanation was phenomenal. Yeah, I think that was really, really good. I think, again, in that 25 to 30 range, I can't say 99% of my patients say they want to lose weight. To me, it's probably 60% want to lose weight from that amount. But I agree. All the lifestyle modification issues you were talking about were really appropriate. And I think surgery is really motivating to people to want to lose that weight too, and to make the right changes. Even though sometimes we'll offer GLP-1 agonists, people don't necessarily want to do that if they can feel as though they can do it themselves and kind of get themselves ready. So then let's turn this around a little bit and make it a more a more dramatic example. Let's say now you're seeing a patient who comes to see you, his BMI is between 35 to 40. So now we're going past overweight and obese to the morbidly obese category. The patient comes to you and says, I'm really struggling to lose weight. I just want to have surgery at this point. I know there's going to be a higher risk. I know my results aren't going to be as good. Will you do my tummy tuck, please, Dr. Rhee?
Yeah, I've had those. That's a great example of patients that have shown up for, I think, all of us. And over time, I've learned, one, many of those patients will say exactly what you said. I just want to get the results done, the surgery done. And you think they have realistic expectations, but many of them don't. They really don't. They really feel like doing the surgery, as Larry said, is a quick fix to achieving something that they feel like they can't realistically achieve on their own. And more times than not, in the past, when I've operated on patients who were high BMI, said, I'm willing to accept whatever the results are. I realize they're not going to be as good. We'll go through the whole procedure and be extremely disappointed because they did not achieve even close to what they thought they would want to achieve. And I'm disappointed because my results are not close to what I think surgery should help people achieve. And it makes no difference if you take someone's waist off 4 or 5 inches when they have a 45-inch waist. There's or 50-inch waist. It's a drop in the bucket. And so, doing those types of procedures for those.
That's a 10% drop. That's a 10% drop based off of what you just said.
That's
It's still pretty.
It would seem like a lot, right? Until the patient's like, I'm still 90% the size that I was. So,
Hey, let me make this more complicated. Let's say, because everything you said is completely accurate, 100% accurate, everything. But let's say the patient, the patient comes back to see you 2 more times afterwards, and somehow you are now convinced that they have realistic expectations. Would you do it?
Boy, you're asking someone to shut up and just take my money here, right? And I'm a plastic surgeon.
All right, this is my take on that. Anybody over 35 in my practice doesn't get an operation. I think that's too high. This is cosmetic surgery. This is not somebody who has cancer and you're trying to cure them. This is a procedure to make a patient look better. And I think, if anything, the standard for the indications for surgery in cosmetic surgery should not be because a patient wants it. I think that we are held to a higher standard when you're doing something that's elective. And so I would feel that somebody who's 35 to 40 is at high risk of not just having a result that they don't like. That's secondary to me. I would be concerned that they're going to have some complication, that they're going to, have a DVT or blood clot or some anesthetic problem or wound dehiscence or infection. All those things are significantly higher in that patient population. So they wouldn't be getting an operation until they lost the weight.
I mean,
Same with you, Sam?
Larry's right. At this point, I do have a cutoff. I'm a little stricter for most patients. I will go up to 35 for a few, depending on the situation. Like you said, it's BMI is a very, very, very inaccurate measurement anyway. But I will say a lot of it is what I'm willing to accept my results to be at this point. I am not someone who just started out in practice. I've been in practice for over 15 years at this point. And everyone that is my patient that is out there with some sort of result is representative of me. And if I don't feel comfortable with whatever that result is, even if the patient says that they're going to accept that result, if that's not something that I feel is representative of what I can do or what I should do, as Larry said, it is cosmetic surgery, and we do have a responsibility to be responsible surgeons, regardless, as Larry said, what that patient may ask for or demand. it is incumbent on me to provide the best results, even if the patient may not realize it.
I liked challenging you guys on that one, and I agree. It's, you know,
I thought you were going to say
ultimately,
your cutoff is 45 or something like that.
I think that I have definitely in the past done tummy tucks on patients whose BMI was between 35 and 40. I'll do a modified version of a tummy tuck. You guys familiar with the Talua abdominoplasty out of Central America, where essentially it is, I guess the way I think about it is as a modified paniculectomy, where you do no undermining of the upper skin flap. You aggressively liposuction everything. You do a neo-umbilicoplasty, and you just do a transverse plication in the infraumbilical area. It's sort of a safer way to do it. And I've gotten results that were okay. That's as good as I'm gonna go with that. I mean, they were the patients usually were happy and sometimes didn't have realistic expectations, just like Sam was alluding to earlier. But I think what Sam said, which I'm also not brand new in my practice. I too want to get results that are representative of me, and I want to be safe, and I don't want to do things that are on the edge. And the fact is in the 21st century, in the year 2024, there are ways to lose weight, even with shortcuts. You guys each use the word shortcut once in a negative, sort of derogatory way. I'll use shortcut in a positive way, in the sense that with GLP-1 agonists in the US, I don't know what it's like in Canada, with how readily available they are, it is possible to get your BMI down below 35 to get results that will be better, and you will have a safer operation. And so delaying it for a few months to get down to that place to get better results for surgery and have a safer operation is absolutely the right thing to do. But I don't mind taking shortcuts, even if they don't modify their lifestyle. I'll use GLP-1 agonists if it comes down to it.
I sometimes have some issues. I wrestle with the fact that we are working on their aesthetics for sure, but in many of these cases, we're not necessarily helping or improving our patient's health. And that's why I really do like lifestyle modification, because I feel like if I can get these patients to live a little bit healthier, in addition to doing what is aesthetically helpful to them, to me, I feel like I've done my job as a physician. I've gotten them to a better place in terms of health and longevity. Plus, I've increased their self-confidence. And so I don't mind, quote, shortcuts, but I also really want to make sure it's not necessarily compromising their health, or they haven't. I want them to learn something a little bit. About the process of becoming healthier during this whole process in terms of body contouring. I see my patients a lot during this time, and I feel like it's an opportunity for me to help them um, realize themselves a little bit better and get a little healthier, hopefully.
I think that actually, I think, Sam, you're sort of advocating sort of a more natural way to lose weight as opposed to using the drugs. But I think that uh, the GLP-1 agonists are going to make very, very substantial difference in the health of obese people in the long term. Right now, it's still early, so we don't know if there's any sort of long-term side effects. But the studies have shown that diet and exercise is, for the most part, not for the most part, for many, many people, is very limited, and it's not always just willpower, so to speak. A lot of it is, physiologic. And I think that the GLP-1 agonists are going to make a big difference. That's part of the reason why they're so popular in the plastic surgery community. Sometimes it's you see people who are actually not that heavy and they're taking them, and I think that's where they've maybe gotten um, an image that they're sort of a shortcut. People who are actually not that heavy taking them. But I think used in the right manner, they're gonna make a big difference, and they'll be a very significant in trying to solve the epidemic of obesity.
Are you seeing an increase in your practice of patients who are coming to you who are already on GLP agonists to begin with? And what kind of a
Yeah,
percentage
definitely.
increase are you seeing with that?
Well, I mean, it was 0 a few years ago because they didn't exist. But I'd say that of the total percentage of patients that I'm seeing that are on GLP-1 agonists, uh, 35, 40% patients who are coming for body contouring surgery.
Yeah.
There's the shortages are kind of over at this point. There's Eli Lilly has come out and said there are no shortages of any doses at this point. So it's readily available for people to get both these compounded versions and the real medication as well. And so, yeah, I see many patients that are on the medication, particularly for patients that have insulin resistance and, are pre-diabetic or diabetic and all that. Just like Larry was saying, there's some health benefits to it. I mean, I think you both have the best interests of your patients at heart. You want them to be healthy, not just getting cosmetic surgery. But there's a role, I think, just like Larry was saying, for GLP-1 agonists in overall health. And we are not primary care doctors. Nothing that we do as aesthetic surgeons delivers any health benefit to our patients, with the exception of breast reduction surgery, which has been shown to have some benefit. So, ultimately, I think, Sam, you're a purist. Maybe Larry and I will want to take a few more shortcuts. Um, but I think we all generally have the same philosophy.
Yeah, the reason in my practice is about 10%, but the reason we see this is because we had to put that on our intake form. Are you taking Ozempic and similar drugs, because there are implications with anesthesia. So when we put that on, I started noticing, maybe about 10% of patients are on it.
Yeah. Well, I think it's been a great discussion, guys. It's always interesting to see where a conversation about something unrelated to plastic surgery, how it ties into plastic surgery. So thanks for the stimulating conversation as always. And until we meet again.